Good morning. Today I'm going to present ventilation management in austere environments. Over the last 6 months, during these presentations, we've covered lots of topics. We've covered fluid replacement and resuscitation. We've looked at the use of vasopressors, and we've looked at the use of vasopressors in different conditions, especially sepsis. Today, we're going to concentrate on the basics of ventilation, your targets being the oxygenation and the carbon dioxide elimination using a ventilator. And for the purposes of today's discussion, I'll be only talking about controlled ventilation, as that is the basic form. And the use of more complex forms will be referred to, but not discussed in detail, as you will need to be in an intensive care rotation or placement for you to be able to see the use of these other modes of ventilation. We know that mechanical ventilation is used for an acute respiratory failure, and this is fairly routine on intensive care. Intensive care can be differentiated between medical intensive care and surgical intensive care. And it will be no surprise to you that the surgical patients tend to spend less time on the ventilator and in intensive care, because once you've corrected the surgical problem, they tend to do well. Medical intensive care patients tend to have acute exacerbations of chronic problems, and these patients are on ventilators, or as a prevention on non-invasive ventilation, and tend to be very difficult to wean off. Or another way of looking at it is an acute exacerbation or an acute exacerbation of a chronic condition. Historically, it was the 1952 Copenhagen polio epidemic that started the use of ventilation. Initially through the iron lung via tracheostomy, or more commonly, certainly in the early phases of the epidemic, medical students were using bag valve masks to ventilate patients. And as a result of this epidemic, other ways of ventilating, like negative pressure chest wall devices or positive pressure face mask devices, were also developed. So non-invasive ventilation is a way of preventing the patient from being intubated and going on to conventional ventilation. And as you can see from the diagram on the right, a mechanical ventilator for intensive care can be quite complex and take some time getting used to. So just for the purposes of today's presentation, I want to briefly consider non-invasive positive pressure ventilation. And the most common one is CPAP, or continuous positive airway pressure, which you can do quite easily, even if your resources are limited. As I alluded to earlier, indications are exacerbations of COPD or cardiogenic pulmonary edema, other causes of respiratory failure, prevention to extubate, but this relies on the patient being responsive, being able to trigger a breath, tolerate a mask, being able to protect the airway, reduce the risk of vomiting, and obviously recent head and neck surgery would be a relative contraindication. There are many ways in which this can be delivered, either by a helmet, full face, partial face, or by nasal mask. And essentially what you're trying to do is trying to get the pH, the PaO2 and the PaCO2 within a normal range. So let's go through some technical information. First, the respiratory drive. The normal respiratory rate in an adult is 12 to 20 breaths per minute. And this is driven by the hydrogen ions in the CSF and modified by receptors in the body. Raised intracranial pressure, as in a head injury, the use of opioids and other sedative drugs can also decrease the respiratory drive, leading to hypoxia and hypercarbia. Work of breathing is the mechanical work needed to maintain oxygenation and ventilation. This is increased when the patient's in pain or is acidotic or hypermetabolic. These are the patients that may need a respiratory support. Tachypnea, secondary to shock, will also result in inspiratory muscle fatigue, which will also require respiratory support. And patients who have increased work of breathing tend to use the tripod stance with their hands on their knees, propped forward with the mouth pursed, and you can see these in severe asthma. The lung compliance is the tendency of the lungs to recoil from an inflated state. It impacts on all respiratory function, and changes are either intrinsic within the respiratory tract, like atelectasis or fluid or blood in the alveoli, or it can be extrinsic. So obesity, pregnancy, burns, and chest wall injury will all influence it. And remember, an extensive burn across the chest will need an escharotomy. Otherwise, you're going to have to ventilate them at high pressures, resulting in pulmonary trauma. Tidal volume is the volume of air exchanged in each breath. It's decreased if there's external pressure reducing lung volume. For example, like a pneumothorax, hemothorax, or a tension pneumothorax. Breath stacking occurs when there is an inability to exhale and leads to the situation known as autopeep, and is caused by an inadequate expiratory time, airflow obstruction, or both, and leads to decreasing tidal volume, an increase in intrathoracic pressure, resulting in hemodynamic compromise. Oxygenation is the binding of oxygen to the hemoglobin alveoli and a release of oxygen in the tissues. If the oxygen delivery is adequate, it allows for efficient aerobic respiration in the cells. If not, the cells will switch to anaerobic respiration with the resultant production of lactate. The one important point about oxygenation is the fact that it is passive. If I paralyze you and leave a oxygen tubing delivering oxygen to via a nasal catheter, the saturations will be normal or higher until the carbon dioxide accumulates and the patient becomes acidotic and collapses. So oxygenation is passive, carbon dioxide elimination or ventilation is active. Diffusion and exchange, we know that at the lungs, oxygen is exchanged for carbon dioxide and vice versa in the tissues. This exchange will be reduced in pulmonary edema, pneumonia, and in ARDS as a result of the increased distance between the alveoli and the capillary, and as a result will give lower saturations. The fractional inspired oxygen concentration, FiO2, is normally as a fraction of 1, or an alternative is in 100% percentage. So in room air at sea level, it's 0.21. In anesthesia, it's 0.3. And in any emergency, you start off at 1. Supplemental oxygen will increase the FiO2 and therefore improve the saturations. Dead space is any part of the airway not taking part in gas exchange. Normally, this is the pharynx, larynx, trachea, bronchi, and ventilator tubing. This is known as the anatomical dead space. In lung disease, there will also be a physiological dead space where the alveoli who are not contributing to alveolar exchange contribute to this dead space. This dead space can be reduced by a tracheostomy and also increased by having an extra length of endotracheal tubing. So let's look at the difference between anatomical and physiological dead space. Anatomical dead space is the air filled in conducting airways that do not participate in gas exchange, while physiological dead space is the sum of all the parts of the tidal volume that do not participate in gas exchange. Anatomical dead space is about 150 mils, whilst the physiological dead space is 150 mils, but becomes larger under certain disease conditions. Anatomical dead space does not involve the gas exchange regions of the lung, but in the physiological dead space penetrates the gas exchange of the lungs that are not being aerated or supplied by blood. So anatomical dead space is not clinically important, but physiological dead space is very important because this is as a result of a disease process. So in this diagram here, you can see you've got mechanical dead space represented by this corrugated tubing to represent an endotracheal tube and a long anesthetic circuit. In a normal ventilation, you've got air being taken up into the alveoli, and that alveoli is transfused by blood. So you've got a VQ match. If, however, the dead space is increased, for example, you may have no blood flow as in a pulmonary embolus, or you may have alveoli that are collapsed, and therefore you have a VQ mismatch. Now, when you have time, I've put this up because this shows you the difference between functional dead space, where there's no gas exchange and no pulmonary blood flow, whilst in the normal you have good exchange and good pulmonary blood flow. And one of the useful equations is the PaO2 minus PaO2 gradient, where in the normal it's between 5 to 15 millimeters of mercury, and when there is a gradient more than 30, that denotes pulmonary malfunction. And to calculate it, you can use the alveolar gas exchange to work out the gradient. The most important monitoring for a critical care patient is the end tidal CO2. The reason for this is because, unlike pulse oximetry that only looks at oxygen saturation, the end tidal CO2 requires an intact respiratory and circulatory system, plus the intact blood vessels and a performing cardiac pump. So your classical capnogram is the expiratory phase and then the inspiratory phase, and the angles between phase 2 and 3, the alpha angle or the beta angle, are important when working out the different aspects of waveforms and working out what is going on. So the end tidal CO2 is a measure of CO2 on end tidal expiration, and there will be a difference between the end tidal CO2 and the PaCO2, and that is represented by the alveolar dead space. That is the parts of the alveoli that are not taking part in gas exchange and represent a disease process. The plateau pressure, or PP plat, is the pressure applied to small airway in alveoli during IPPV. It's measured at the inspiratory pause, and if it's greater than 35 centimeters of water, there is a risk of barotrauma. If you look at the capnograph, you can see a different possibilities. This is representing the normal waveform. If you're hyperventilating over a period of time, the end-tidal CO2 will decrease. On the other hand, if you're hypoventilating a patient, the end-tidal CO2 will increase over a period of time. In bronchospasm, and that can be also due to asthma, rather than just a bronchospasm caused iatrogenically, you have the loss of the alpha angle, and you've got what we call a shark fin waveform. In emphysema, which is more restrictive, the reversal of phase 3 is reversed, and you can see the sloping down of the plateau, the alveolar plateau. During CPR, you will have a flat line, but as you get a resumption of this circulation, you'll get an increase in waveform, as shown in this diagram here. In apnea, if the patient's breathing on their own and doesn't breathe, you're going to get a flat line. But remember, a flat line can also be due to an emergency, such as a disconnection, or a cardiac arrest, or a pulmonary embolus. In the course of time, the monitor will zero, and so you will get a dotted line whilst it's doing that. In hypoperfusion, where there's less blood going into the lungs, you're going to get a steady decrease in end-tidal CO2 height, very similar to what you get in hyperventilation. And if you get a tube displacement, you will get a loss or a distortion of the waveform. And if the patient's completely extubate, then obviously it'll be a flat line. If the patient's trying to breathe on their own, there'll be extra breaths in between the conventional waveforms, and that will give you an idea that the patient is trying to breathe on their own. And finally, if a patient's ventilated, you can get this, what we call the curare cleft. Curare was the first muscle relaxant ever used, and it represents the difference in performance between the left and the right lung. You can also see this if a patient's being ventilated in a lateral position, then obviously the lower lung will not be ventilating as easily as the upper lung. And you can also get this cleft impact on the alveolar plateau. Next, let's look at the different types of hypoxia. Hypoxia is defined as oxygen deficiency in tissue sufficient to impair function, and the function that is critical is the brain. There are 4 kinds: hypoxic, hypemic, stagnant, and histotoxic. In hypoxic, the patient is not getting enough oxygen in the environment, or a decreasing atmospheric pressure, as in unpressurized transport at high altitude, and is easily rectified by supplemental oxygen. Hypemic is a reduction in oxygen content or capacity due to an inadequate amount of red cells, and that will occur in hemorrhage or anemia, or if the red cells are abnormal or impaired, like in sickle cell, or in carbon monoxide poisoning, or the various different forms of abnormal hemoglobins. And here you need to correct the cause by supplying a blood transfusion of the appropriate amount of hemoglobin, a minimum of 7 grams per deciliter. Stagnant hypoxia occurs in circulation where the oxygen content is adequate, but the circulation is inadequate. And this occurs in congestive cardiac failure or vessel occlusion, and in high G forces. And obviously, depending on the cause, you need to treat the cause to improve this. Histotoxic is when, despite the fact that you're delivering oxygen to tissues, the body tissues are unable to utilize oxygen, and this is classical with cyanide poisoning. And the treatment for cyanide poisoning is giving intravenous hydrocobalamin, and this absorbs the cyanide poisoning. But remember, if you're working in this kind of environment, you must not put yourself in danger. So as I've said to you before, oxygen is passive, whilst ventilation is an active process. Minute ventilation, or MV, is tidal volume times, which is about the PaCO2, and this dictates the blood flow to the brain. This is why when you hyperventilate, you get lightheaded and you faint. So this is really critical when you're trying to treat a head injury, where you're trying to keep the PaCO2 within normal levels. So whenever you are ventilating somebody initially, there is a tendency to hyperventilate patients, and you must make a conscious effort to reduce the rate down to about 10 to 12. Otherwise, you will hyperventilate, reduce the PaCO2, and reduce the blood flow to the brain. Peak inspiratory pressure, or PIP, is the highest pressure that's obtained in inspiration. Ideally, it needs to be below 30 millimeters of mercury, because above it, you're more likely to cause barotrauma. An increase in PIP is due to the increase in resistance in the respiratory system, like as in attention pneumothorax, inadequate exposure time, or edema of the lungs. The way you monitor your ventilation is by doing serial arterial blood gases, which is the golden standard for evaluating the acid base, the oxygenation, and ventilation, and making the adjustments on the ventilator. These are the normal ABG values, but when you are monitoring these patients, you can use either of these charts to work out where they are and check out if the patient's moving back into a normal range as with time. Now let's look at ventilated terminology. There are several modes of ventilation, either volume targeted or pressure targeted. As I said to you before, the one mode that you need to be aware of, because it's the basic mode and is available on all the simple ventilators or transfer ventilators that you may come across in a low-income environment. So volume targeted, the volume is kept constant and inspiration ceases when that preset tidal volume is delivered. So the airway pressure will be variable and the constant flow waveform. The other alternative is a pressure targeted, where the volume is variable, the peak airway pressure is fixed, and you've got a decelerating waveform. And we look at waveforms in a second, because these are quite complex depending on the mode of ventilation. So the tidal volume is the volume of gas in a breath, and it is set between 4 to 8 mL per kilogram of the ideal body weight to prevent overdistension and barotrauma. The frequency is your respiratory rate, so the minute ventilation is basically your tidal volume times respiratory rate, which is about 5 to 10 liters per minute in an adult. The inspiratory phase is between 0.7 to 1 second, and the expiratory time is based on a ratio of the inspired to the expired ratio. In a normal patient, it's 1 to 2, but in asthma, you need a longer time for in expiration to allow for expiration to occur, and the IE ratios change to 1 to 3 to 1.5. The PEEP is the positive pressure at end expiration, and the normal physiological value is 5 centimeters of water. So if you're setting a patient on a ventilator, 5 centimeters of PEEP is your basic minimum. And what it does, it increases the end expiratory lung volume, reduces air space closure at the end of expiration, or we call it alveolar recruitment. And PEEP is the other alternative way of improving oxygenation. You can improve oxygenation by increasing the FiO2 or applying PEEP. And here at the bottom, I've given you the equation to work out the ideal body weight. So let's look at PEEP. So if this is the normal lung in end of inspiration, and if you've got in expiration, you can see the collapse to a different, to a much lower level. By applying PEEP, you recruit more alveoli, and therefore you can see the distension of the lung at expiration with a PEEP valve is more than without a PEEP valve. And this alveolar recruitment improves the oxygenation as you've got more surface area for oxygen to diffuse across. So the good side of having PEEP is that it prevents atelectasis, recruits collapsed alveoli, and improves oxygenation. But the downside is that it can cause barotrauma, it can cause gas trapping and hypercapnia, and it reduces venous return. This is why when you're intubating a critically ill patient, quite often you will get a drop in blood pressure because venous return is reduced and therefore the blood pressure drops. So you've got two alternatives. You can give a bolus of fluid to make up for that reduced venous return, or you can use a vasopressor like a bolus of epinephrine, as we discussed in previous lectures. If the patient's self-ventilating, then putting a PEEP makes it harder for them to breathe, and this needs to be taken into account when you are doing a weaning process. There is another phenomenon about ventilating patients called the recruitment maneuver, which is really a way of improving arterial oxygenation and enhancing alveolar recruitment. And the way we can do it in a osteo environment is basically attaching the patient to a back valve mask and giving a vital capacity maneuver, inflating the lungs up to 40 centimeters, maintaining it for 15 to 26 seconds. There are other ways of doing recruitment maneuvers, and this is best seen when you're looking at different ventilation modes, or when you're working in an intensive care unit. Pressure support ventilation delivers flow at a set pressure to overcome resistance of the airway and the ventilatory circuit, and also used to support a spontaneously breathing patient, and is known as BiPAP. Flow per minute is the velocity of gas delivered to the patient, and if the higher delivery is faster and inspiratory time is reduced, you're going to get problems with high airway pressures. Peak inspiratory pressure, measured in centimeters of water, is the total pressure to deliver the tidal volume you've dialed, and will depend on the airway resistance, the lung compliance, and chest wall factors. The trigger sensitivity is the effort or the negative pressure needed for the patient to trigger a ventilatory breath, and this can be set at -1 to -2 centimeters of water. Just remember that the moment you put a patient on a ventilator for IPPV, you are pushing the gas into the patient, as opposed to inspiring a negative pressure within the thoracic cavity to as occurs in spontaneous respiration. The pressure alarms are used to alert either for under pressure or overpressure, and you set it up 10 centimeters above the peak inspiratory pressure, and a low alarm 5 centimeters below the peak inspiratory pressure. And the high pressure alarm must be less than 35 centimeters of water, and it can be either due to increased resistance or reduced compliance as the the patient's trajectory goes on. Low pressure alarms will be due to air leaks, also failure in the ventilatory system, or at its worst, a disconnection from the patient. Ventilator dysynchrony occurs when the ventilation and the patient's respiratory mechanics are not matched. This can be due to the patient being agitated or in respiratory distress, and this must be first checked out before paralyzing the patient, because paralyzing the patient synchronizes the ventilation and the patient's respiratory mechanics. So it may be a presentation of a patient being agitated. So look for other surrogate signs of the patient being distressed, like diaphoresis, tachycardic, hypertension, and a failure to wean. If you have air trapping and auto-PEEP, as we've discussed before, this will reduce the venous return, cause hypotension, and if left, will either have a cardiac arrest and or a barotrauma. So if you have this in an emergency, disconnect for a few seconds and consider reducing the tidal volume, altering the IE ratio, or switch the mode and treat the airway resistance. Now, in order to mechanically ventilate the patient, you need to intubate the patient, either through an endotracheal tube through the nose or through the mouth. Or in patients that are going to be long-term ventilated, you need to think about a tracheostomy. So a cuff tube within the trachea is the only secure way of protecting the airway. So the indications for endotracheal intubation will be for patients who need airway protection, as in coma or a poor level of consciousness. Secondly, for suction of secretions. This is better done via tracheostomy if it's going to be a long time on the ventilator. 3, to overcome respiratory deaths where the patient's exhausted, the work of breathing is high and the patient's fatigued. And so you would sedate and paralyze the patient to facilitate the ventilation. And finally, overcoming an upper airway obstruction, the classical one being upper airway burns, inhalational burns, or anaphylaxis involving the upper airway. The saturations less than 90% can be either due to poor perfusion or due to a reduction in FiO2 as you go up in altitude. The end tidal CO2 will be higher than normal, especially in the absence of a tachypnea. If it's below the normal range, it would suggest hyperventilation. If you've got a combination of a low end tidal CO2 and hyperventilation, please exclude sepsis or a metabolic acidosis. So I repeat this: if the end tidal CO2 is low and the patient's hyperventilating, consider sepsis or another cause of a metabolic acidosis. So we would mechanically ventilate the patient as to in a head injury to keep the intracranial pressure low, to improve oxygenation, to reduce the work of breathing, as in a severe asthma or in a huge response to pancreatitis, or to increase the functional residual capacity by recruiting alveoli to improve oxygenation, or to control lung stretching, spontaneously breathing, as you would do in a non-invasive ventilation. And finally, chest wall injuries, when they're severe, the chest wall needs to be stabilized, and for this to be allowed, you need to sedate, analgese the patient to tolerate mechanical ventilation. Now, the different types of ventilation are available on the intensive care, but for today's purpose, I'm only going to look at the spontaneous ventilation, which we've discussed before in terms of CPAP, the use of the bag valve mask, and I'm only going to look at controlled mechanical ventilation, or IPPV, from all these different ventilation modes. And for your information, I've tried to give you an overview of conventional ventilation and also those of hybrid modes when you do your placement on intensive care. So let's go back to basics. The bag valve mask is familiar to you all. It's used in an emergency to support the ventilation. In ICU, it's used for pre-oxygenation prior to a rapid sequence induction, or if you're going to manually ventilate, inflate the lungs, as in the rescue ventilations, as I explained previously. You can do it by a face mask or a supraglottic airway, or via an endotracheal tube or a tracheostomy tube. It has a self-inflating reservoir bag. The valves are either simple flap or duckbill. The reserve bag volume is about 1600 mils, and the tidal volume is judged by the movement of the chest. It has 15/22 millimeter connectors, so these can be connected to endotracheal tubes. It can be used both for spontaneously breathing and for positive pressure ventilation. People forget that the maximum fraction inspired oxygenation is just about 0.8, and in an adult, a flow rate of 18 to 15 liters per minute can give you an FiO2 of 0.6. There is also, in more sophisticated bag valve masks, the PEEP valve. So to summarize, there are only two ways you can improve oxygenation. One is by increasing the FiO2, and two, applying PEEP. For carbon dioxide elimination, you need a good, adequate minute ventilation, and this can be increased either by increasing the tidal volume or the respiratory rate, or both. And the opposite applies when you're trying to increase the PaCO2. So for your future reading, I've given you a fantastic summary of ventilator notes by Dr. Nick Mark. The one mode that we are all used to is volume control, but these are the sort of more common ventilatory modes used in intensive care, and I hope that you refer to these during your placement there. For the controlled ventilation, the airway, the waveform is important. This is the level of PEEP. Then you've got your peak airway pressure. This is your plateau pressure, and then you've got your downward slope. So this bit is inhalation. This is when the breath is held, and then this represents the expiratory phase. This part of the slope is the resistive pressure, and this part of the slope is the elastic pressure. And as you can see, if you increasing mean airway pressure, you can either increase the flow, increase the peak pressure, lengthen the respiratory time, increase the PEEP, or increase the rate. And this is something that you need to consider when you're having problems, for example, with a patient in bronchospasm. The other waveforms that you will get with the different types of ventilation are here for you to refer to when you get exposed to seeing these different modes of ventilation being used. But this is the one that we are all familiar, which is volume control. So before we think about setting up a ventilator, let's look back at history. When I first started training in the 1980s, there was the rules of 10. So for ventilation, you took the patient's body weight in kilograms, multiplied it by 10, and that gave you the tidal volume to be dialed onto the ventilator, and then you set the ventilator at 10 breaths per minute, and that was it. Now you can see that over time this is excessive because, first of all, the body weight is not to be use, but it's the ideal body weight. And I've given you that formula earlier on this lecture. The rate at 10 breaths per minute is fine, but I think it's this large tidal volume that cause problems, because when you use large volumes, you tend to have alveolar overdistension, barotrauma, and complications. So this is why we try to minimize lung injury by what we call protective ventilation. So it minimizes the excessive regional lung stretch. It recruits alveoli that are collapsed, and it reduces ventilator-induced lung injury. So instead of the rules of 10, what we're saying is use a tidal volume of 6 mils per kilogram, so much lower than the 10, and ideal body weight. A moderate PEEP, remember the basic PEEP value for a normal patient is 5 centimeters of water, and keeping the plateau pressure less than 30 centimeters of water. So to protect to perform protective ventilation, you use as low an FiO2 as you can. Keep the plateau pressure less than 30 centimeters of water. Use 6 to 8 mils of kilogram per predicted body weight, and set your PEEP to adjust to limit atelectasis and shunt. And you can refer to a PEEP table for that. So your initial settings will be volume controlled. Here is a different concept. And the reason why I want to give you this one rather than the simpler one of 6 mils per kilogram, because this is a range depending on the state of the patient and what disease process and comorbidity the patient has. And you can give a higher respiratory rate to maintain the ventilation of 4 to 8 mils, adjusting the end-tidal CO2. A minimum of 5 centimeters of PEEP and titrate. In an emergency, you would start off with an FiO2 of 1, and then reduce as hopefully the patient improves, and you keep the IE ratio 1 to 2. However, in an asthmatic or in a COPD patient, you want to increase the IE ratio to 1 to 4. So you've got a long expiratory phase to allow the lungs to empty during the period of expiration. And as you can see, you can have a range of tidal volumes from 6 to 8 mils per kilogram, and an increase in PEEP in especially ARDS. And in an emergency, the highest FiO2 is 1. But remember, keeping patients with a high inspired oxygen concentration also has its issues, and this includes free radical oxygen formations, and these will damage the lungs and give you acute lung injury. Troubleshooting, a dope is a good mnemonic for displacement, obstruction, pressure within the system, and the equipment. And this is something that you need to look at, and for further information, you can look at a ventilator management algorithm where the patient's intubated, and then you make adjustments according to the saturation. And also this will also determine what you have to do if the patient is on a ventilator for a long period of time and eventually passes the spontaneously breathing test to allow extubation. Now, I just want to cover a few things about pulse oximetry. Remember, pulse oximetry uses 2 different wavelengths, the one at red light and infrared light, and it assumes that the body contains only 2 types of hemoglobin, oxyhemoglobin and hemoglobin. Therefore, when you start getting more exotic hemoglobins like carboxyhemoglobin or methemoglobin or sulfhemoglobin or cyan hemoglobin, you're going to get abnormally high levels. The pulse oximetry only gives you an idea of the saturations at the periphery and there are lots of factors can affect it, both circulatory and ventilatory factors. The pulse oximeter is a indication of oxygenation, but is not a indication of ventilation. This is why the capnogram is a better monitor than a pulse oximeter. Get used to looking at your pressure, the pulse oximeter waveform. You've got your systolic pressure, you've got your dicrotic knot when the aortic valve closes, and then your runoff for your diastolic pressure. In a patient who is critically ill and just been intubated and is on the ventilator, if in inspiration the peaks of the pulse oximeter drop during inspiration, you need to put in the appropriate fluid to minimize what we call the respiratory swing. The shape of the waveform will depend on whether the patient's got a normal valve. But for example, in the cases of aortic stenosis, starting with the mild form, you can see now there's the loss of the dicrotic notch because you've lost the elasticity. And then as the stenosis of the aortic valve gets worse, you get a flatter waveform. Going back to the capnography, which is my preferred monitor, you can tell a lot from the shape of the waveform. And let's look at why the end tidal CO2 can be elevated or decreased. It'll be elevated if the metabolism increased, as in hypothermia, when we discussed things like heat stroke or neuroleptic syndrome, or if the patient's shivering or in pain, or if the respiratory tract is being insufficient or is being depressed by opioids or sedatives in chronic lung disease and the impact of analgesia and sedation. It'll also be affected if the circulatory system is compromised, as you have in an increased cardiac output or the release of tourniquet. If you've got a tourniquet for a long period of time, especially on the lower limb, a release of tourniquet will release a lot of lactate, CO2, free radical oxygen scavenging. And in a case of a head injury, I tend to hyperventilate the patient slightly before the release of the tourniquet, so as to attenuate the impact on the rise of PaCO2, increasing the cerebral blood flow, increasing ICP, and compromising somebody who's already got a head injury. And if bicarbonate is used intravenously, then you'll get an increase in CO2 production as the bicarbonate is neutralized. For getting a decreased end tidal CO2, you can get it in hypothermia, whether it's accidental or deliberate, as in post-infarction, where hypothermia is used as a therapy. Metabolic acidosis, where you get a compensatory alkalosis, respiratory alkalosis, or if there's dysfunction of the respiratory system, either by alveolar hyperventilation, bronchospasm, or mucus plugging, or in a circulatory system with hypotension, sudden hypovolume like an aortic aneurysm rupture, cardiac arrest, or pulmonary emboli, which will also be very sudden. This is a better waveform for the different capnograms for you to look at. Shark fin of bronchospasm, a sloping alveolar plateau in high compliance lungs, loss of waveform as in disconnection or cardiac arrest, or a severe pulmonary embolus, mechanical obstruction, which is very similar to the bronchospasm, but in air trapping, you'll see the baseline going up, but just in a pure obstruction, the baseline is at the same level. You can get oscillations of the heart as it beats away, pressing on the lungs to give you the oscillations, especially in the inspiratory phase. and then a decreasing waveform when you've either got a hyperventilatory state or in a low cardiac output state. The complications of mechanical ventilation can be due to equipment, malfunction or disconnection, incorrect settings, and contamination. This stresses the importance of health-associated infections. It could be pulmonary, airway intubation, damaging the teeth, vocal cords, or trachea, ventilator-associated pneumonia, ventilator-associated lung injury, barotrauma, or oxygen toxicity, which we've hinted about. Or it could be a drop in cardiac output, or increase in right ventricular afterload as an overdistension, or reduce in blood flow to the gut with high PEEP or mean pressure in the airways, or an increase in ICP, especially in hyperventilation, and fluid retention due to a drop in cardiac output, resulting in reduced renal blood flow. Other systems, you can get gut distension, especially if you are manually ventilating a patient. If you use vigorous ventilation, you'll insufflate the esophagus and start filling up the stomach preferentially. You can also get mucosal ulceration all along the oral and nasal cavity, depending on whether it's an oral or nasal intubation, or bleeding as a result of trauma. As patients remain on the ventilator, the diaphragm, which is a muscle that is active in spontaneous respiration, is now not active, and it's the diaphragm fatigability that makes weaning a problem, and also the importance of nutrition to maintain a muscle status, and also make sure that the patient is adequately fed. When the patient's on the ventilator for a period of time, we must make sure that the patient's asleep and comfortable with adequate sedation and analgesia. Remember, the patient can get agitated even at lower levels of sedation and pain relief. It's important that day-night cycles in intensive care are maintained, that the alarms are switched off so that the patients don't get disturbed by alarms. And obviously, eventually, the results of neurocognitive complications like microemboli to the brain, or a worsening of delirium due to multiple causes. And this is especially worse in patients who've already got dementia as a comorbidity. And finally, the degree of increasing intensity of intervention was clearly defined by the Berlin definition. If you've got a normal patient, you would look at a low tidal volume ventilation, and as the patient gets disease gets more and more complex, you'd use low to moderate levels of PEEP, and if they're getting worse, higher PEEP, paralyzing them so that the machine, the ventilator, takes over the patient's efforts completely. You start using a lower tidal volume, and you make sure that the peak plateau is reduced, or try and remove the carbon dioxide by an extracorporeal means, or placing the patient to a prone position, as we've seen in the COVID pandemic. This is labor intensive and improves the VQ match, that is ventilation and blood flow in the lungs. And then you've got your high frequency oscillation ventilation, inhaled nitric oxide, and eventually ECMO, which was used in the COVID pandemic for the worst patients. And as you can see, the ratio of the PaO2 over FiO2 will determine whether somebody has got a mild disease or got severe forms of ARDS. Now, when you are considering weaning a patient off the ventilator, there are so many things that need to be taken into account. The degree of sedation, How is the brain functioning? Are the patients alert, or is their level of consciousness now so low that they can't cooperate? What is the status of the chemoreceptors in the body? What is the degree of reliance of mechanical stimuli to allow the respiratory drive and the respiratory motor output? That is using the respiratory muscles, especially the diaphragm, but the intercostal muscles as well. Make sure that the patient's no longer paralyzed, and this is important, and you can do this by trainer 4 monitoring. And has the patient got enough effort to have a respiratory drive? For example, if you've got a C345 cervical injury, C345 drives the diaphragm, and therefore in these patients, there's not going to be much of a respiratory effort, because the diaphragm, being a major respiratory muscle, is no longer functional. And so what you're trying to do is reduce the amount of lung injury, and hopefully the diaphragm hasn't atrophied or injured, like in a diaphragmatic hernia, which will impact on the respiratory mechanics of the patient. So the weaning is really a difficult process in about 20% of patients who you're trying to extubate. And as I've described just with the last slide, you need to make sure that the patient's no longer paralyzed, that you've minimized the degree of muscular wasting, especially that of the diaphragm, and it hasn't atrophied and become fatigable. The state of the central nervous system is also important, and a brain where the patient is alert and able to cooperate, and there is no damage to the spinal cord, especially at C3, 4, and 5, which drives the diaphragm. Is the oxygenation adequate with an FiO2 less than 0.4 and a PEEP at the low levels of 5 to 8 centimeters of water? Is the cardiovascular system stable? Because if the cardiovascular system is not stable, remember the cardiac and the respiratory systems work in synchrony, and therefore you've got instability of the cardiac system, whatever the cause, whether it's an arrhythmia, whether it's pump function, you're going to have problems weaning. And one aspect of this is that if you've got increased fluid retention, that's going to make extubation more difficult. The older patient and those patients with chronic lung disease or any other reasons for respiratory depression will also become difficult to extubate and wean. So these patients are likely to be reintubated, and the problem with reintubation is that it's common in those 20% that fail. And when you intubate them, you've got an added recurrence of hemodynamic consequences, where you intubate somebody, you ventilate them, you're increasing raised intrathoracic pressure, reduces venous return, reduce cardiac output, reduce blood pressure. And this is where making sure the patient's well filled, making sure you've got fluid resuscitation, or in an emergency boluses of diluted epinephrine are useful. But in terms of long term, you increase the infection and therefore increase sepsis and therefore mortality. So in weaning in a low income environment would be using the T-piece with positive spontaneous ventilation pressure of 5 to centimeters of water, or using SIMV. And here I've given you a weaning protocol for somebody breathing spontaneously with a T-tube. And this was covered by Dr. Sanger when he discussed the weaning of a patient, of a multiple trauma patient. So in order to wean successfully, the patient must be optimized, suctioning must be completed, adequate humidification so that the air that the patient's being ventilated on contains no humidity, so drying of the secretions of the respiratory tract must be avoided. Consider use of bronchodilator therapy, good nutrition. I can't put emphasis on any patient. The quicker you feed, the better. Optimal positioning, we know that a 30 degrees head up position, if there's no contraindication like in a spinal cord injury, is best in that it improves the mechanics of ventilation, but it also reduces the chance of aspiration of acid from the stomach. The patient must be able to cooperate and follow instructions by the staff. You must have enough staff to be able to extubate a patient, because this is a dangerous time. Extubation and intubation are the more critical periods where things can go wrong. Therefore, you must have everything to be able to re-intubate the patient using an RSI if things don't go well. And finally, you must make sure that the patient's not over-sedated. Dr. Sanger did talk about predictions of weaning success using the spontaneous breathing trial, where the frequency is less than 38 breaths per minute, a tidal volume greater than 300, and a FVT ratio less than 105. I've given you other predictors of successful weaning, including the crop index, for your information. The one negative thing against a weaning success is having a high positive fluid balance. Criteria to define weaning failure is listed here for you to look at, and you can see again it's a complex combination of respiratory, cardiac, arterial blood gases, level of consciousness, and muscle function. The other complication of being on a ventilator is VAP, ventilator-associated pneumonia. Other complications being ARDS, pneumonia, pulmonary embolism, lobar atelectasis, and pulmonary edema. VAP is defined as a new lung infiltrate plus clinical evidence that the infiltrate is of infectious origin, shown by a new onset of fever, a purulent sputum, an increase in white cell count, and a decline in oxygenation as defined by the American Thoracic Society. It occurs very early, within 48 hours of intubation. This is why we try and extubate a patient as quickly as possible. The differential diagnosis will be blast or penetrating chest injury. So ventilator-associated pneumonia is a common health acquired infection, and it can be nosocomial, which is endemic. This is the importance of being working in an as sterile condition with PPE, if at all possible, and it occurs in 5 to 15% of all patients put on the ventilator. Some of the infections can be quite exotic. For example, you've got the ABC complex that have been found during military operations in the Middle East. But it's not just military operations. We had a couple of patients who were injured bike riding in Morocco in the desert, where the bike exploded. They got multiple burns and local infections of ABC. So it isn't limited to the military alone. So to reduce VAP, monitor your patients carefully, daily assess the patient for extubation. And the other criteria for a good, successful extubation is having a hemoglobin above 7 because of improving oxygen delivery. A core temperature is less than 38.5 because a high temperature is hypermetabolic and makes the work of breathing more difficult, and obviously the patient being alert. Or you can avoid intubating. You can try non-invasive ventilation. And then finally, like in sepsis, you can use a VAP bundle, which is basically paying a really obsessional attention to respiratory equipment in terms of the humidifiers, making sure they change when soiled or not working properly, drain the condensation. This is a good place for Pseudomonas infections to proliferate. Check your humidifiers, make sure they're not increasing the resistance of ventilating a patient. Prevention of person-to-person transmission, avoid cohorting, standard precautions, using PPE, being obsessional about tracheostomy care and in tracheal suctioning. Another thing you can do is to prevent mucus plugging before you extubate a patient. Make sure that you also clear the oral secretions that accumulate above the cuff. Reduce the degree of prevention of aspiration by putting the head of the bed at 30 degrees, as we discussed previously. Extubate them as soon as possible. If you're putting a feeding tube, make sure that the tube is in and not gone into the trachea. And this is best verified by X-ray, or better still, by ultrasound in an austere environment. Oral care of the oral cavity is so important. There was a phase of using chlorhexidine, but now this has been found not to be that beneficial. Just a good washout and suctioning of the oral cavity. You know what it's like when you haven't brushed your teeth for a little while. Imagine what it's like for the patient to be on a ventilator for several days. And then finally, prevention of postoperative pneumonia by encouraging postoperative patients to take deep breaths regularly. These are done by the respiratory therapists or the physiotherapists. You can use incentive spirometry to improve the rehabilitation of the respiratory tract and start early rehabilitation. And finally, you would consider antibiotics for 7 days if the condition of the patient warrants it. If the patient's then got to undergo aeromedical evacuation, you remember the flight may be multiple and be over several days. We know that altitude will decrease the PaO2. Ventilated patients at 30 degrees head elevation to improve the mechanics of ventilation and also to reduce the gastric aspiration of acid contents. Make sure you've decompressed the stomach either through an oral or a nasogastric tube. The oral is preferred because the nasogastric tube, when it's in place, can block off the entry to the various sinuses and result in sinusitis. Make sure the patient's well hydrated, both systemically and respiratory, by using a humidifier. Do a repeat chest X-ray at least 12 hours before the flight, so you have a baseline, and correct any thing that can be corrected as a result of taking this chest X-ray. Do not extubate your patient less than 4 hours prior to takeoff, because this is the time when the patient is extubated, they may require re-intubation. So discussion with the Aeromed team is critical. And remember, if you've got a multiple flight over several days, nutrition needs to be maintained, and ideally with a small bowel feeding tube with a peristaltic pump so that it's not gravity fed. Finally, I just want to remind you about the usefulness of prone positioning in the COVID pandemic, and this is because in a prone position you are improving the VQ, that is the ventilation and blood flow match in the different alveoli in the lungs, some of which are diseased and some of which are normal. So I hope I've given you a quick overview of ventilation management in an osteo condition. This is really the basics. I've given you some of these slides are lectures in their own right, and I hope that in the course of your revision, you will look at those topics in greater detail. And finally, I will leave you with 2 references. One from the COROM field book, and the other one, which I found very useful, is a podcast from the Prolonged Field Care website that will give you another look at the subject. Thank you for your listening. Goodbye.
It's okay.